adverse effects, metallic taste, constipation, and it is pro-arrhythmic. Then if we talk about flecainide, it is a potent blocker of sodium and potassium channels. It will be blocking potassium channel, but it will not be prolonging the action potential duration in QT interval. And it will be maintaining the sinus rhythm in supraventricular arrhythmia. So this was all about the class 1 antiarrhythmic drugs, and we have further classified class 1 drugs into class 1A, class 1B, class 1C. Now we'll be coming to the class 2 drugs, which are the beta blockers, which depress the phase 4 depolarization of pacemaker cells. And it will be these drugs will be decreasing the heart rate, increasing the effective refractory period, prolonging the action potential duration by decreasing AV conduction. It will also be reducing the myocardial oxygen demand, and it is well tolerated and safer in recommended doses. What are the different uses of beta blockers in arrhythmia? It is used for beta blockers are used for controlling the supraventricular arrhythmias, whether it is atrial flutter, whether it is fibrillation, or whether it is any type of paroxysmal supraventricular tachyarrhythmia. As well as it will be helpful for treating tachyarrhythmias caused by adrenergic stimulation, like in hyperthyroidism, fibromocytoma, or during anesthesia with chemotherapy. If we talk about use of beta blockers in arrhythmias, digitalis induced tachyarrhythmias can be treated with beta blockers, as well as beta blockers being given prophylactic in post-MI. Ventricular arrhythmias in prolonged QT syndrome. Then if we talk about esmolol, it is a beta 1 selective agent. It is and having very short elimination of life, that is of about 9 minutes, and it is metabolized by RBC esterases in the rate control of rapidly conducted atrial fibrillation. As well as if we talk about the use with anesthesia and SPTs, that is supraventricular tachyarrhythmias. Then if we talk about the class 3 drugs, the mechanism of action of class 3 drugs are that these drugs will be increasing the action potential duration. These drugs will be increasing the refractory period by blocking the potassium channels. And class 3 drugs will be prolonging the phase 3 repolarization without altering the phase 0. So you are looking in this picture that class 3 drugs like Amiodarone, Verapamil, and Sotalol, these all are blocking the potassium channels. So they are producing their antiarrhythmic drugs by inhibiting the potassium channels. So if we talk about Amiodarone, which belongs to the class 3 antiarrhythmic drug, it is the long-acting drug, iodine containing long-acting drug. And this drug has multiple mechanism of action. Like these drugs will be prolonging the action potential duration by blocking potassium channels. These drugs also will be blocking the inactivated sodium channels. These drugs will be blocking the beta blocking action. These drugs will be blocking calcium channels, as well as these drugs will be decreasing the conduction, and this drug will be decreasing the ectopic automaticity. So you should know about the different mechanism of action of Amiodarone, which belongs to the class 3 antiarrhythmic drugs. So if we talk about pharmacokinetic profile of Amiodarone, it is variable. It is having variable absorption, like in between 35 to 65%. It will be having slow onset, 2 days to 7 weeks, and duration of action is week to months. If you talk about uses, it can be used for both supraventricular as well as ventricular tachycardia. Adverse effects include, if you talk about cardiac issues, there will be heart block, QT prolongation, bradycardia, cardiac failure, and hypotension. If we talk about pulmonary side effects, there will be pneumonitis leading to pulmonary fibrosis. There will be blue discoloration of skin, as well as there will be some corneal microdeposits. If the person is taking this drug for a much long time, there will be some GIT disturbances like hepatotoxicity, and this drug will be blocking the peripheral conversion of T4 to T3, and it can cause hypothyroidism or hyperthyroidism. So this is the picture showing the adverse effect of amiodarone, in which you can see the bluish discoloration of the skin and corneal deposits. And like we have discussed the mnemonic of lignocale, this is the mnemonic of amiodarone, in which A stands for antiarrhythmic drug, amiodarone is antiarrhythmic drug, M stands for multiple actions. You all know that these drugs have potential, specifically amiodarone, have multiple mechanism of action, as well as it is iodine containing. It can be used orally, and the duration of action is very much longer, that is about 3 to 8 weeks. Then if we talk about action potential, duration, and effective refractory period, both will be increased. There will be resistance, atrial fibrillation, ventricular tachycardia, recurrent ventricular fibrillations, which are the major indication of this drug amiodarone. Then, on prolonged use, pulmonary fibrosis can occur and neuropathy may occur. If we talk about the adverse effects of eye, there will be some corneal microdeposits may occur. Then if we talk about sotalol, which is the beta blocker, as well as dofetilide and ibutilide, they are the selective potassium channel blocker, less adverse effect, and they are used in atrial fibrillation to convert or maintain the sinus rhythm, and it may cause QT prolongation. Then in last, we will be discussing about the class 4 group that are calcium channel blockers, and class 4 drugs will be slowing the phase 4 spontaneous depolarization and slow conduction in tissues depending on calcium current, such as the AV node. So calcium channel blockers will be inhibiting the invert movement of calcium, and due to this, there will be decreased contractility, automaticity, and AV conduction also. So verapamil and diltiazem belongs to this group. If we talk about verapamil, it can terminate paroxysmal supraventricular tachyarrhythmia. It can control ventricular rate in atrial flutter or fibrillation. And if we talk about drug interaction of verapamil, it will be displacing the digoxin from binding sites, and it will decrease the renal clearance of digoxin. Then there are some other antiarrhythmic drugs, among which adenosine is one of the most important drugs. And if you talk about adenosine, it is the purine nucleoside having short and rapid action. So do remember that adenosine is having the rapid action, and it will be, if we give intravenously, it will be suppressing the automaticity, AV conduction, and it will be dilating the coronaries. It is the drug of choice. Do remember, please do remember, it is the drug of choice for paroxysmal supraventricular tachyarrhythmia. Some adverse effects include nausea, dyspnea, flushing, and headache. So if we talk about the mechanism of action of adenosine, it will be acting on specific G protein coupled adenosine receptors and activating the acetylcholine sensitive potassium channels in SA node, AV node, and atrium, which will be causing the shortening of the action potential duration, hyperpolarization, and this will be causing decreased automaticity, which in result will be causing or inhibiting the effect of cyclic AMP with sympathetic stimulation, causing decreased calcium currents. So you all know that if the calcium currents are reduced, then this drug will be producing the anti-arrhythmic effect. and there will be increased AB nodal refraction and inhibition of duration of action potential. Then there are some drugs like atropine, which is used in sinus bradycardia, digitalis, which is used in atrial fibrillation and atrial flutter, and magnesium sulfate, which is digitalis induced, which is used in digitalis induced arrhythmias. If we talk about the mechanism of action of magnesium, its mechanism of action is unknown, but it may influence some sodium potassium reticulases or sodium channels or potassium channels also or calcium channels also. If we talk about the use of magnesium, it is used in digitalis induced arrhythmias. If hypomagnesemia is present and refractory ventricular tachyarrhythmia, as well as torsidy contest, even if serum magnesium level is not. So these are the drugs of choice. Drugs of choice, different types of arrhythmias. You should kindly do remember these drugs which are used in different types of arrhythmias, like in sinus tachycardia. Beta blocker propranolol is being used in sinus tachycardia and atrial extrasystole. If we talk about atrial fibrillation of flutter, Amiodarone, Esmolol, Verapamil, digoxin can be used. If we talk about paroxysmal supraventricular tachycardia, Adenosine and Esmolol is used. If we talk about ventricular tachycardia, then lidocaine, procainamide, and Amiodarone can be used. If we talk about ventricular fibrillation, lidocaine and Amiodarone are the drug of choice. Then if we talk about AB block, then atropine and isoprene are the drug of choice. So dear students, please kindly remember these different drugs of choice in different types of arrhythmia, because that is very much commonly being asked, that what are the different drugs of choice in different types of arrhythmias. So this will be ending our today's session about the different drugs that are used in arrhythmias, and there's a little video regarding this topic, and after watching this video we can have a little question answer session. If there are any queries related to this topic, you can ask me then, inshallah.
Antiarrhythmic agents are drugs used to suppress abnormal rhythms of the heart. They act to either interfere with the dynamics of cardiac action potentials by blocking a certain ion channel, or block the sympathetic effects of the autonomic nervous system on the heart to slow down heart rate. There are 5 classes of antiarrhythmic drugs. Class 1, sodium channel blockers. These drugs bind to and block the fast sodium channels that are responsible for the depolarizing phase in contractile myocytes. The result is a slower depolarization with a smaller amplitude. Slower influx of sodium results in a smaller flow of positive ions through gap junctions to adjacent cells. The adjacent cells take longer to reach the threshold required to generate a new action potential, ultimately resulting in a slower propagation of action potentials through the myocardium. This reduced conduction velocity helps to suppress formation of reentrant circuits, hence the use of these drugs for treating reentrant tachycardias. Class 1 agents are divided further into subclass 1A, 1B, and 1C. These subclasses differ in the strength of sodium channel blockage, and in their effect on the duration of action potentials and the effective refractory period, the ERP. While subclass 1C has no effect on ERP, 1A prolongs and 1B shortens ERP, respectively. Changes in ERP may have different outcomes for different types of arrhythmias. A longer ERP generally reduces cardiac excitability, but prolonged repolarizations may increase the risk of torsade de pointe, a type of tachycardia caused by after depolarizations. Class 2. Beta blockers. These drugs bind to beta-1 adrenergic receptors and block the sympathetic influences that act through these receptors. Sympathetic nerves release catecholamines, which act to increase SA node firing rate and cardiac conductibility, especially at the AV node. These activities may precipitate arrhythmias. Beta blockers suppress sympathetic effects, thereby decreasing heart rate and slowing down conduction through the AV node. The latter is particularly useful in treatment of tachycardias that originate upstream of the AV node, known as supraventricular tachycardias, or SVT. Note should be taken, however, that beta blocker treatment may cause AV blocks. Class 3. Potassium channel blockers. These agents block the potassium channels responsible for the repolarizing phase. The result is a slowed repolarization, hence a prolonged duration of action potentials and refractory period. This reduces the heart's excitability and suppresses reentrant tachycardias. However, these drugs may also cause arrhythmias because slow repolarizations are associated with longer QT intervals and increased risk of torsade de pointe. Class 4. Calcium channel blockers. These drugs block calcium channels that are responsible for depolarization in SA and AV nodal cells. Blocking these channels results in a lower sinus rate and slower conduction through the AV node. However, because calcium is also involved in cardiac myocyte contraction, these agents also reduce contractility of the heart and should not be used in case of systolic heart failures. Class 5 includes all